When to test is a really important question in allergy in general. And the important thing for doctors and patients to know is that a positive test is not a diagnosis. What people don't really know, and many doctors don't remember, is that there are many people who have a positive test but don't have the allergy, so to speak. There are tons of people walking around with a positive test to peanut, but they eat peanut all the time. There are tons of people walking around with positive tests to insect stings, and they get stung and nothing happens. We don't know why. There's a lot of important research to be done, but that's important to know. So you just doing a test doesn't prove that someone has it or is going to have an allergic reaction. So we have to limit our testing to people who, for some reason, we feel are at increased risk of having an allergy or reaction. So an insect allergy, that means someone had an allergic reaction to a sting. So we don't just go and test general people, because we're going to find people who have positive tests but really don't have the allergy.
I think as an otolaryngologist or an ear, nose, and throat surgeon, I would really recommend that an allergist refer a patient with chronic rhinosinusitis to an ENT if the patients are still having symptoms in spite of the regular use of topical steroid sprays or topical steroid medications delivered through a nasal saline irrigation method or through the exhalation delivery system. Sinus surgery has been found to be very helpful for patients with chronic rhinosinusitis, as the goals of surgery are really to help reduce the inflammatory burden within the nose and in the sinuses. It's also helpful for the delivery of topical steroids into the sinuses after surgery. So there are merits with sinus surgery for patients with chronic rhinosinusitis.
I'll start back with just one sort of background. You know, that there are a couple of available treatments for treating food allergy. And this was the first time that these two treatments, omalizumab and multi-allergen oral immunotherapy, have been compared. And we did find that the omalizumab was superior. And when we do an intent to treat analysis, what happens is that anyone who drops out of the treatment for any reason is considered a treatment failure. And in this stage 2 of the outmatch study, there was a very low rate of dropouts in the omalizumab side of the study, and quite a high rate of dropouts in the multi-allergen OIT side of the study. And what that did really is drive the results toward the advantage of omalizumab.
Me and my lab group, we are very confident that not only is it this autoclaving, this process diluting the peanut from its proteins, but we think it's actually changing it in a different way, making this a very unique substrate. It's changing it in such a way that we might have all these new things in this peanut. There's still some level of those allergens there, which is important to reduce tolerance, but way less of it intact. And otherwise, we get different pieces of all different lengths and sizes and shapes. And I think that is where really the money might be for this potential new treatment for peanut allergy.
So WAYPOINT is actually a clinical study, and it's a phase 3 randomized double-blinded control study looking at the effect of tezepelumab in treatment for severe nasal polyp. So the way we decide whether or not that tezepelumab would be effective in our patients with chronic sinusitis with nasal polyp is to look at two primary endpoints. One was looking at the polyp size, the other one was looking at symptoms of nasal obstruction or congestion, very similar. And what we showed was that the change in the nasal polyp score was about 2 between the placebo group and the treatment group at week 52, which is tremendous. The other second primary endpoint was looking at nasal congestion. And they basically went from moderate to severe to basically mild to mild symptoms. So these are things that patients notice.